Vandana, and my friend Dr. Tirunavukarasu, who is the President Director of the Indian Psychiatric Society. I'm indeed delighted to be here this morning, participating in this workshop, but I never expected that I would be asked to come and speak. I wanted to listen to the Minister, the Secretary, and perhaps later, but I understand that the Minister is going away by a later flight. So I'm very thankful to Vandana for giving me this opportunity to begin this workshop in a way by making a brief presentation on the district mental health program. And that is the predominant way in which mental health is being taken to remote and rural areas. I'm very happy to be making this presentation because for about 30-35 years I've been associated with this program, because I joined the National Institute of Mental Health and Neurosciences many years ago in 1975 as a postgraduate trainee, and that was a time when the community mental health unit in Nimhan started under the leadership of the late Professor Ravi Kapoor, who was the first professor of community psychiatry. And one of the programs which the Department of Psychiatry at the National Institute of Mental Health and Neurosciences helped develop is the Bellary district program, district mental health program, which later became the prototype for the implementation of the national mental health program in the country. Now, the mental health program is being implemented. There are lots of comments, good things, bad things, etc. We will have a lot of time during the rest of the day to discuss various aspects of the implementation, what has gone on right, what has not gone on right, etc., etc. But it's very rarely that somebody asks anybody to talk about the genesis and the evolution, the very initial days, why was this thought of, how did this start, etc., etc. Because it's history. In fact, in one of the recent evaluation of the district mental health program, one of the comments and the recommendation is that there should be an analysis of the historical development of the program to understand why it is being implemented the way it is being implemented. So I'm very grateful to Banyan and its director, founder director Vandana, for giving me this opportunity to talk about this. Now, when you look at the public mental health program in the country, I would look at the past 30-35 years in three phases. The first phase would be from the mid-1970s till the mid-1980s, because that was the time when the initial demonstration projects, pilot projects were developed. The awareness about taking mental health care from the psychiatric hospitals, mental hospitals, etc., into the community was being developed. Till then, of course, mental health care occurred only in psychiatric hospitals, which used to be called asylums, which later became mental hospitals. In Chennai, of course, you have the big Chennai mental hospital. In Bangalore, we had the Mysore mental hospital, which later became the Karnataka big mental hospitals. That was the only way mental health care was occurring. Then, of course, it moved out to general hospitals, and it was in the mid-70s that the idea of taking mental health care into the community, into the villages, into the rural areas, into the primary health center, first was mooted. So the first phase of development of mental health care is a period between 1975 and 1985. After those initial enthusiasm, talk about all this, people said, okay, now this is fine, should be done, but how do we go about doing it? And then in Nimhan's, being the National Institute of Mental Health and Neurosciences, Government of India gave it the task of developing a pilot program of delivering mental health care through the primary health centers. And that is how in the Bellary district in Karnataka, a project came up. 85 to 90, the project was implemented, 5 years, a lot of experience was gained, etc., etc. I'll tell you about the structure of that program a little later. And then, of course, by that time, the National Mental Health Program was approved by the Central Council of Health and Family Welfare, which is the highest policy-making body in the country as far as health is concerned. It's constituted by all the health ministers, health secretaries, directors of health services. The highest policy-making body of the country said that mental health should be implemented all over the country. But then there were no funds. It's all good to say that mental health should be implemented, it should be taken to the primary health centers, community health centers, etc. So the third phase began somewhere in 95-96. That was in the 9th plan, when a budget head was created for the mental health program, particularly the district mental health program. And subsequently from 96 till now, it has been steady growth. Initially it was in 4 or 5 districts. There was a small amount to begin with in the 9th plan. The total allocation for mental health program was 28 crores. It went up to 130, 140 crores in the 10th plan. And in the 11th plan, the initial proposal was for about 1,000 crores, but ultimately the Planning Commission and the Ministry brought it down to about 437 crores. So today, the mental health program, district mental health program, is being implemented in about 127 states. And Tamil Nadu is one of the leading states where it is being implemented in large number of districts. So this is the, the broad overview of the development of the district mental health program. Now, what were the factors which contributed to the genesis of this kind of a program in the mid-1970s? Again, I would consider about 4 or 5 important factors. Till then, the popular belief was that mental illness of various types was predominantly a problem of the developed world, developed countries in the Western, hemisphere, northern Western hemisphere. In countries such as ours, India, and large number of other developing countries, there's no mental illness. I mean, there might be an occasional one. Of course, then we have the mental hospitals to treat them. The popular belief amongst professionals, amongst administrators, amongst everyone was that mental disorders are not a problem in developing countries. In fact, some of the very initial studies, I mean, there were very few studies, few field studies till the 60s from developing countries. Most of the data on mental disorders came from USA, Canada, England, etc. But by 1960s, 70s, there were field surveys done in India, Nigeria, and all that. In India, it was done in Agra, in Vellore, the Christian Medical College, Vellore, Dr. Abraham Varghese and others. Dr. Nandi, the late Dr. Nandi, did a major survey in Agra, in Uttar Pradesh. And what they found was that all kinds of mental disorders, psychotic disorders, neurotic disorders, anxieties, phobias, hysteria, all these kinds of disorders were prevalent more or less to the same extent in our country as it is prevalent in other places. So this was a news to a lot of people. People thought that mental disorders are not there in developing countries because life is okay, things are quiet, we have large families, we believe in religion, spirituality, etc. Maybe the actual prevalence rates were slightly different. I mean, that is an issue which is still not resolved completely. There's a World Mental Health Survey which is being done, which is looking at rates in different countries in the world. That's a different issue, but it was for the first time realized that there were a large number of people who were suffering. Maybe they were getting treatment in traditional healing centers. Maybe many of them became homeless, wandered around. There was high mortality among people who had severe mental disorders because there was no care available. And that is when initially there was a World Health Organization's expert committee which said that to deliver care for people with mental disorders in developing countries, you will never have enough number of mental health professionals, such as psychiatrists, psychologists, social workers, etc. Highly trained people. We didn't have so much of training facilities. Even today, we don't have so much of training facilities. It's only maybe a couple of hundred, maybe 300, 400 people who pass out every year. So in the mid-70s, an expert committee of the World Health Organization said that the only way mental health can be taken to those who are in need